this Nepal Poison Information Center. This is the first institutional poison information center in Nepal. And we're based at TUTH Hospital, and we are running through sort of a multi-partnership through Brown University in the US with TU running the show in Nepal, and nonprofit AS Foundation also supports in Nepal. And this is part of our goal of building capacity and building education in toxicology in Nepal. So we bring different experts every month, international experts as well as national experts, to talk about key issues in toxicology in Nepal. This will help you. I'm going to ask everyone to mute yourself during this webinar so we don't have to listen to what's happening in your background there. Yeah, so before we move on, I just want to briefly remind everyone that the Poison Center is available 24/7 for service, and the phone number is 450-2011. So please save that phone number if you have not. Poison Center को phone number चाहिँ 450-2011 हो है, 24/7 उपलब्ध छ। र तपाईहरुलाई कुनै पनि poisoning को cases-मा problem छ या केही problem नभए पनि, if you just want to report it or you have questions, expertise चाहिएको छ भने, we have international experts, national experts that are available to help at all times. So कृपया यो phone number चाहिँ save गरेर राख्नु होला, 450-2011, म यो तल chat-मा पनि लेख्छु। So without further ado, let me just introduce our Poison Center team before we introduce our webinar today. So our Poison Center is staffed by our 3 spies, and spies are specialists in poison information, and they are Dr. Rajesh Sharma, who's here. You can see him on the video. He's our lead spy, the first spy of the Nepal Poison Center. And we have Dr. Ayushma Pandit, I don't know if she's here, and Dr. Rishika Karki. And those are our 3 specialists who usually answer your phone call when you call. And they've been well trained by Emory University, and they get continued training. So they're pretty good at answering your questions. And then we also have from our TU side, the lead from TU side is Dr. Rakesh Gimire. And he's joined here as well, and you've seen his face. And then you have from our AS Foundation side, I don't know who's here, but I saw Anjana Thapa, and maybe Dr. Yagya is here also. Please, very excited to have this team here, and very excited that we are able to host this webinar. Thank you all for joining. We have 2 great speakers today. So I'll just introduce the first speaker for now. And our first speaker is Dr. Krishna Prasad Acharya. He's a senior consultant anesthesiologist at NAMS. He's at National Trauma Center right now. But he has years and years of experience working in Snakebite at Bir Hospital, and has done tremendous work in Nepal as far as working around Snakebite and teaching. So he's going to talk for about 10 to 15 minutes today first. And he's going to give us an overview of Snakebite scenario in Nepal, and just kind of keep us in the loop around Snakebite. And then will be followed by Dr. Ashish Bhalla, but I'll give his introduction once we're done with Dr. Krishna's presentation. So Dr. Krishna Acharya, the floor is all yours. Please welcome.
Thank you, Dr. Ramu. Am I audible to all of you?
Yes, you are.
Okay, thank you. I'm gonna present my topic. The slide is not shifting. Slide shifter. Okay. Okay. I am going to tell a story about a guy, a 13-year-old boy from Bhutan. Last year, during the month of May, a friend of mine called me from Bhutan that a boy came with a history of snakebite while he was trying to climb a tree. I was driving my car. Then I immediately told him that please send me a photo of the guy and photo of the bitten part also. he immediately sent the photo in my WhatsApp. I saw the photo. His eyelids are drooping, and his bite side in the hand has got some necrotic swelling. Then I immediately realized that the patient has got cobra bite. Then I told sincerely that it's cobra bite. Please manage aggressively and immediately. I told him, and I kept on my driving car. And after half an hour, I reached home. Then I called back to the person who called me for the advice, and I asked what happened to the boy. Actually, the friend of mine was just health worker, health assistant. He told me that he informed to medical officer on duty, and medical officer on duty informed to his senior medical general physician, and general physician advised to refer the patient to higher center because he doesn't have any experience of handling snake bite, and he doesn't have any training for snake bite. So it's better to refer the patient to the higher center. That means either Nepalganj or Butwal. Both are more than 100 kilometers away. Unlucky, the boy got collapsed in 1 hour because of the bite of cobra. Patient can die within 1 hour. So it's very difficult to reach the patient to Nepalganj in 1 hour via ambulance. It's only possible via heli lift also only. So patient lost the life because of lack of exposure and experience in health workers and medical doctors. The irony is the person who got MD degree in Nepal, he did not get any experience and education in snake bite management, neither in graduation college, medical college during MBBS, nor in MD. So it's the irony of Nepal. Another case. Yesterday also, I was going home from National Trauma Center. A person, unidentified number, called me repeatedly 3 times. Then I called back. Then the boy was telling that I have sent you a photo of a snake that beat a middle-aged man, and he had come to our center in Bardia. Then I saw in the photo of the snake in WhatsApp. I immediately recognized that the snake is non-venomous. Though I could not identify which snake is this, I immediately forwarded this picture to a friend of mine, Mr. Sunil Sapkota. He immediately identified this checkered killback, which is non-venomous. Then I talked the person in photo here in video call WhatsApp. Then I assured him that the snake which bit him is not venomous, it's just non-venomous snake. Don't worry. Even if you are diabetic and hypertensive, just have a injection tetanus and stay cool in home. That means we had saved his expenses of traveling in an ambulance from Bardia to Nepalganj, which cost around 5,000, plus his anxiety and other costs also have been saved. And patients might have other complications because of anxiety and hypertension. So teleconsultation and telemedicine can actually do miracle in case of snake bite. This is the example. Talking about the global scenario, we can see here in the screen, globally there are 1.8 to 2.7 millions in venomings and around 1 lakh deaths per year. And majority of the deaths occur in Asia regions, which Nepal also falls in the Asia region. Asia, Bangladesh, Sri Lanka, Nepal. These are the main snake-prone area in Asia, and which has got more than 57,000 deaths in a year. Each year, millions people do die because of snake bite, and mainly poor people who live in low and middle income countries are mostly affected. So, though it was neglected tropical disease since the beginning, but WHO only identified it, declared snake bite is a neglected tropical disease in 2017 only. And last year, we cannot forget the two very tragic incidents in Kapilvastu and Sinduli district, where two brothers were sleeping together in a bed in the ground, and both had got unidentified illness with symptoms of pain abdomen, vomiting, and gradually increasing weakness. Initially, their guardian did not identify what happened to them. They just got into domestic measures for relieving vomiting and pain abdomen. Gradually, their condition worsened, and they took their children to local health centers, very delayed. And in the local health centers also, the health workers there, they did not want to take risk immediately starting the treatment. And also that problem is with visitors attitude also, because visitors also doesn't believe or trust the local health workers. So both way the children are taken away to the higher center, and they both the children in in Chinduli as well as in Kapilvastu, they died on the way to the higher center. Thus, this is the scenario of Nepal. And to talk about the snakes available in Nepal, there are total 89 species of snakes, which among 89, 21 are venomous one. And each year, the study has shown that 20,000 people are bitten by snakes in Nepal, and the peak month for snake bite occurrence is Shravan. Usually that month also falls Nag Panchami. That's why Nepalese people they worship Nag, that is a snake. And among 77 districts of Nepal, 26 districts are at high risk of getting a snake bite. In the photo, we can see a red lined districts in low tribal. In Nepal, it's also an occupational hazard to the farmers, plantation workers, and herders, fishermen, because of habit of sleeping on the floor without using mosquito net, keeps people at risk of biting, especially karet, because karet is the one which comes to bite human at night, and it bites without any symptoms, without any knowledge to the patient who is without any knowledge to the person who is being getting bit. So मान्छेहरूले चाहिँ सर्प करे सर्पले राति आएर बिस्तारमा सुतेको थाहा नै पाउँदैन, जसरी एउटा कमिला टोकेको थाहा हुँदैन त्यसरी नै सर्पले टोक्छ र जान्छ। यो कुराहरू चाहिँ रातमा विशेष त जुन कपिलवस्तु र जुन सिन्धुलीमा घटनामा पनि राति सुतेको बेलामा करे सर्पले आएर टोकेर उनीहरू थाहा नपाइकन त्यस्तो बिस्तारै आउँदाखेरि त्यो बिरामीहरूको चाहिँ डेथ भएको थियो। अर्को कुरा चाहिँ हामी कहाँ प्री हस्पिटल एन्ड प्री हस्पिटल केयर र ट्रान्सपोर्टेसनको पनि एकदमै पुअर डिसिजन भएको हुन्छ। तत्कालै चाहिँ हामीले बिरामीलाई टोकेको ठाउँबाट हस्पिटलसम्म लानको लागि चाहिँ हामीले एम्बुलेन्सै कुर्नुपर्छ भन्ने धारणाले गर्दाखेरि पनि एम्बुलेन्स आउन टाइम लाग्नेको भएको भएर विशेष गरेर कोब्रा बाइटको केसमा चाहिँ यसले चाहिँ टाइम हामीलाई चाहिँ we may not have sufficient time, enough time to get transport. So we can get the patient can be carried away in the bike also if people have got bike in their home. And another problem is snake bite management is taken as very risky issue, in Nepalese context. So many health personnel cannot take risk. So they tend to refer the patients to the higher center, so that they can save their head. Actually, people who are referred from the local health centers and they die on the way, and they came back to the local health center, and they have attacked the health personnel who have referred the Snakebite. So now there is another way that we should try to treat the patient locally. We can contact to the higher authority, to the expert who are expert in managing Snakebite. So, and also the people, general people should also be motivated to seek the treatment at the local center. And the snakes which are available in Nepal are basically 4 types of snakes. The most lethal one is cobra, which I already said that it can kill a person within 1 hour. Especially common cobra, monocellate cobra. These are the mostly involved snakes. Other is karet, which usually bites in night time at the bedside, and its immunization involves gradual process, and ultimately if person doesn't know the snake bite event, ultimately patient will reach to the hospital very late, and that time if the patient doesn't get right treatment, patient can die. In Vibridia family, we have viper, that is green pit viper, Himalayan pit viper, or mountain pit viper. They are very common in mountainous and hilly regions. Though they are not that lethal, but morbidity is very high. And ironically, we don't have any anti-snake venom to treat such viper bite in Nepal. Though in Vibridae family, Russell's viper is we can get in Western Terai as well as mid Terai. We have got anti-snake venom for treating the envenomation of Russell's viper, and it is multisystemic envenomation. It involves hematotoxicity, nephrotoxicity, as well as neurotoxicity. So, treating Russell's viper is more challenging than treating cobra and karet. In Nepal, for last 3 years, we can get the registered number of snake bite cases. We can see the highest number were last 2078-79, and only 10 to 15% only in venomous, otherwise non-venomous. These are the underreported cases, and we can see here Lumini Pradesh has got the highest number of Koshi Pradesh, and Lumini Pradesh has got highest number in 2077 and 78, whereas in 2078 and 79, 371 were the highest number in Lumini Pradesh. Government of Nepal, Ministry of Health and Education, Health and Population, Department of Health Services, Epidemiology and Disease Control Division is the authority to look for snake bite management, and actually it has the responsibility for capacity building of health workers and anti-snake venom and anti-snake venom purchase and snake bite management training, and endorsement of standards of management and on-site coaching and mentoring. These are the process, or these are the responsibility of the EDCD. And this is the snake bite management centers according to the province. There are total 88 centers, and 20 more are added this year. So there are more than 100 snake bite management centers in whole Nepal. And I want to repeat one point. Medical education in MBBS and MD with case exposure is very, very rare. We can see only one medical college, medical university, that is BP Koirala Institute of Health Science in Dharan, is the only institute which teaches and exposes the medical students to the snake bite. Otherwise, we cannot get any medical college among 20 medical college in Nepal. They don't have any snake bite exposure. I studied in 2 years. I did not get any snake bite case in MBBS, even in MD. So people are, medical persons are not getting adequate knowledge about snake bite. And engagement of snake preservationists, rescuers in mainstream of snake bite prevention and prevention of death from snake bite is crucial. So snake bite management team should include them. Their roles is very vital. I already gave examples of that in the case of the Bardia incidents. And I want to mention some photos of the people which deserve mentioning. The first picture is the Professor Dr. Sanjeev Sharma, who was my first teacher of snakebite management. I usually used to do teleconsultation with him when I was posted in very hospital. That time I had zero knowledge about snakebite. And Dr. Julian White was the international mentor of mine. He invited for toxinology short course in Australia, in Adelaide, and that also gave me a lot of insight in snakebite management. And I want to mention Mr. Dr. Paras Pandey, who is currently working in various Nepalgans. Because of him, I have come to National Trauma Center, working there for 8 years, and he had already got all skills and abilities and knowledge of mine transferred to him, so that I am very confident he will handle all the snake bite management in Western Nepal. So I am very much thankful to Dr. Pandey. And here, the Dr. Isabella Khodka and Dr. Nirbal Rizal, these are the non-medical people. Both are non-medical doctors, PhD doctors, and they are very enthusiastic about snake bite prevention. So they have collected thousands of dollars for snake bite prevention in Nepal. They have applied snake bite prevention Nepal website, and they have got lots of information materials published in different languages of Tarai as well as Nepali, and they had done a lot in the prevention, in the spreading of message how to prevent from snake bite. And there are three people. These are snake bite preservationists as well as rescuers. Mr. Kamal Devkota, who is also a trainer for snake bite management. And Mr. Sunil Sapkota, I mentioned in the second slide, he was the one to identify the snakes. We are snake bite management expert, but they are snake experts. They can recognize which snake is this, which is venomous, which is not venomous. So they have to be included in the loop of snake bite management team. Similarly, Prabhat Bhandari, which is also a snake bite preservationist and snake rescuer in Dang area, which is very enthusiastic about the snake bite prevention service and management. So I am very, very thankful to all of them. And I am, in the end, I am very much thankful to all of you who attentively listened to me. Thank you.
Thank you, Dr. Acharya. This was really, really fantastic overview. And
please, I'm welcoming.
Yes, yeah, thank you so much. This was really helpful to just understand and get an overview of what's happening in the country. There are a few questions, but we don't have time for questions right now, so we'll answer those questions at the end. So please continue asking your questions, and then we'll ask our speakers questions at the end. So please thank Dr. Krishna Prasad Acharya. Now, next, we're gonna kind of dive into a very different topic, but a very important topic when it comes to toxicology and poisoning in the country. We have Dr. Ashish Bhalla, who is a professor of internal medicine, and he is from Postgraduate Institute of Medical Education and Research in Chandigarh, India. He has been the past president of Asia Pacific Association of Medical Toxicology. He has done he has published numerous times. He has been involved in medical education and toxicologic education in South Asia and beyond for a number of years. And I've got to know him from my mentor, Dr. Kazi at Emory, a number of years ago. So he's very well. We are so fortunate to have him join us and give his talk today, focusing on aluminum phosphide, which is a big cause of mortality in our country as well as in the region. So we're more than happy to welcome Dr. Ashish Bhalla for our speaker series today. So please, Dr. Bhalla, the floor is yours, and you can share your screen if you can. Thank you.
Thank you. Thank you so much. It's always a pleasure to talk to people from different parts of the world. And as you just mentioned, Ziad, your mentor, is a very, very dear friend. We worked together. We go a long way back when he had hair on his head and he wasn't unmarried. And he was as wild as any of the snakes you can see in Nepal. I just wanted to mention a very interesting talk. I always, we had a meeting in India and we were discussing a snakebite management, document for next 10 years we're making. And it was mentioned that Nepal has a document on management of snakebite. So that is congratulations to all of you that you already have it and we didn't have it. We're trying to make something which kind of includes everyone across the board in management of snake bites. Where I trained in the central part of India, I used to see a lot of cobras and a lot of viper bites. But here in northern part of India, we see around 150 to 200 crate bites in a year, and we see them in a span of 3 months. So you can understand the kind of volume or the morbidity and mortality associated with snake bites, and the potential of looking at them is there. Now, shifting gears, I'm going to talk about something which is very, very different. I bring you greetings from Chandigarh. This is my city, and this is my institute, and I have no conflict of interest. So I'll start with a very simple case. 48 years young female brought to ED after alleged consumption of a powder, and she dissolved in a juice. She had vomited twice, which contained no blood. She was conscious, but she was incoherent. She responded poorly to commands, had cold extremities. Pulse rate was 120, BP was 70 by 50 millimeters of mercury in right arm in supine position. Her respiratory rate was 26 and saturation was 90% on room air. Now, what can you do at this point in time in the ED? You examine, you investigate. Her blood sugar was 100 milligram. Urine output put in a catheter, it was 10 ml per hour. ABG showed severe metabolic acidosis with bicarb of 9, lactate of 8. ECG showed tachycardia. There were no arrhythmias. She was put on a monitor. And the point of care ultrasound showed a full IVC and contracting heart with slight dilatation of LV cavity. So a possibility of aluminum phosphide poisoning, because we see it day in and day out, was kept. So is this the classical presentation for an ingestion of aluminum phosphide, either tablet or powder? This is the very classical presentation. But for an inhalational exposure, it is very different. We do not see too much of an inhalational exposure, but it has been reported from various parts of the world And the latest reports have, the Ziad was a part of that, and Tharwat was a part in, they reported the first case of metal phosphide exposure in a young male in Lebanon. They had never seen it earlier. So I was in consultation with them and I was guiding them what is to be done. Is this the only formulation available? No, the other formulations are also available, which are metal phosphide formulation. And the most important one in India is zinc phosphide, which is used as a rat poison. Now, it's very important to note for the Poison Information Center that when you talk about rat poison, and if it has come from India, it could contain zinc phosphide, it could contain superwarfarins, but it could also contain yellow phosphorus. So if somebody says rat poison, you need to be very careful because the clinical presentation and the management of zinc phosphide is very different from yellow phosphorus and is very different from superwarfarins. So aluminum phosphide is a grain fumigant, is a rodenticide. It is used widely in India, available freely. We have stored some grain at my home, and we put a couple of tablets of aluminum phosphide in that stored grain, in that container which stores grain. It's available as tablets, pellets, and sachets, which contain granules, and it has different brand names. The first large series was published by my mentor, Professor Surjit Singh. I'm eternally indebted to him in 1985. It is a very common poison in northwest and central India, isolated reported from southern part of India. But there are increasing reports from Iran, from the Middle East, from Morocco, Jordan. Cases have been reported from as far as Colombia and Ecuador. And as I said just now, I saw a case report from Lebanon, which has been the first case reported there. Now, if you look at what is the pattern of poisoning, this is the discrepancy in the data. If you look at the right side, the findings, or the topic says, the heading says the findings. This is the finding from the forensic group, where the autopsies were conducted in poisoned patients, and they found that aluminum phosphide, the major killer. But this data on the left of that is the toxic numbers. And this is the data which comes from the poison centers. And if you look at the most common poisoning there, it is 40% plus are household compound poisonings. And these household compounds include corrosive detergents, whatever is available at home. And insecticides are just 1/4 of them. So if you look at the data from the poison center, you will find a very different kind of a pattern. But if you look at the data from a tertiary care center or a medical college, you will find a very different kind of presentation, because only the very severe cases would be referred to the tertiary care centers. That is giving you a skewed kind of a data. This is our own experience, and we said way back, we published this 2009. Says the case fatality ratio with aluminum phosphide was very high, and although the most common poisoning was cholinesterase insecticide poisoning, but the most common poisoning which causes mortality was aluminum phosphide. Over the years, things have changed a little bit, and now we are seeing more of drug overdoses and corrosives. And this is the last data where which we published just a couple of years ago. It says that pesticides followed by pharmaceutical drug overdose and corrosive injections were the common poisonings. And among the pesticides, there is an increasing number of herbicides which is being seen now. What is the scope of the problem? This is a data which has been just published, and this is a data which talks about the projected market of aluminum phosphide in the world. And it says that in the world, the projected market in the market in 2024 was 196 million US dollars worth. And in next 10 years, it is supposed to grow nearly 1.5 times. So it's around, by around around 30% to go up to 252.48 million. So the total increase is going to be around 3.1% during 24 to 2033. That is in 9 years. So you can presume that aluminium phosphide is likely to stay with us, and it is likely to stay with us for a very long time. And when it is available in the market, you are likely to see more and more patients. So what are the classic clinical features? The classic clinical features when somebody has ingested a tablet or a powder or a granule of aluminium phosphide, number one is GIT, that is nausea, vomiting, abdominal pain, and diarrhea. Then it is followed by hypotension, shock, arrhythmias, heart failure. You have tachypnea, crepitation in the chest. Because of severe pump failure, you have ischemic hepatitis, which gives rise to jaundice and raised transaminases. Because of the poor perfusion to the kidneys, you have acute kidney injury, oliguria, and CNS involvement. Although dizziness, restlessness is common, but altered sensorium, hypoxia is just pre-terminal. And then you have very severe metabolic acidosis on investigation. Can there be some dramatic presentations? This is a presentation which was reported from Iran when they put in a Ryle's tube and the phosphine gas came out through the Ryle's tube. There was a spontaneous ignition scene at the end of the Ryle's tube. I've never seen this. I may have seen more than 2,000 to 3,000 cases of aluminum phosphide poisoning. This is something I've never seen. Most of the Western doctors, ED trained physicians are very scared of the exposure to phosphine gas, secondary exposure. Once they see a patient and they want to put in a Ryle's tube and they want to, perform a gastric lavage, they are scared. But I have worked in ED for more than 20 years now. As I said, more than 3,000 patients. I'm still alive. So, secondary exposure, and none of my residents have ever had a significant secondary exposure. So, I don't think it is a real issue, but you should always take precautions. Okay. Now, this is a report which is a very similar kind of case which has been reported from China, and it is a very similar kind of case which has been reported from majority of the Middle East countries, where a young patient comes to the local hospital for treatment of nausea, vomiting, chest tightness as main complaints. Routine blood tests, liver and kidney functions were normal, and ECG was performed, and the patient was sent home. This is a classic presentation of inhalation of phosphine gas. Now, this patient was working in a granary where the grain was stored and where there was a lot of aluminum phosphide tablets, and he got inhalational exposure. He was sent home initially, but he came back with a respiratory distress, and an X-ray was performed later on, which showed diffuse GGO, a cardiac enlargement, and the ECG showed an STT changes, which was diffuse. So for these patients, if somebody gives you a history of that kind, should never be sent home, should be kept in the emergency, at least observed and re-evaluated till the time you think that these people are absolutely safe to be sent home. So if you have to look at three things which will define aluminum phosphide poisoning, it is profound hypotension, altered sensorium, and low pH. They are the hallmarks of this poisoning, and they are indicator of high mortality. If all three of them are present, the mortality is likely to be 99% plus if you do not perform heroic measures. Inhalational exposure, as I have already said, is acute gastroenteritis, maybe initially without hypotension, but later on would develop hypotension. How does aluminium phosphide work? Very simple. Any moisture, aluminium phosphide comes in contact with it. It releases phosphine gas, and what is left behind is aluminium hydroxide. Phosphine gas is very interesting that it gets accumulated in a closed container where you put in the tablet and the grain and there is some moisture. But once you open the container, it just escapes in the air. So until unless you are in a large enclosed space, which cannot be at once open to the air, and you enter that container or you enter that room where the phosphine gas is built up, there you will have a problem. Otherwise, if you're storing grains at home, you put it in a container and you open the container in an area where there is a lot of ventilation, you are not less or you are less likely to develop any significant exposure to phosphine. We've done quite a bit of work on this. It causes oxygen uptake inhibition, inhibitor of mitochondrial respiration, direct effect on electron transport chain, and it inhibits insect catalysis. My mentor, Dr. Singh, and me have done this study, which was published way back. It showed a significant inhibition of cytochrome CX oxidase activity. Then we demonstrated in further studies that there is a significant effect on electron transport chain complexes, catalases, and there is rising of oxidative stress markers in the platelets in patients who have severe aluminium phosphide poisoning. Now, we have a process in which all the patients who consume poison, they undergo an autopsy, and there are different kinds of findings which have been noted. Most common is blood-tinged froth at nostrils and mouth, which indicates a pulmonary edema, intense garlic-like odor from the gastric contents and from the body. They found tablets, pieces in the stomach, and you find congestion basically of all the organs in them. This is another paper. If you want to note this down, you note it down. This just summarizes in one chart here all the basic clinical signs on one side, the cardiac signs, which shows tachycardia or bradycardia at a later date, severe myocarditis, QRS broadening. There could be ectopic beats. Pulmonary edema, ARDS, is an important component of respiratory involvement. You have AKI, acute liver injury, hemolysis, hypomagnesemia, hypoxia, and you have multi-organ failure. And then you have increased lipid peroxidation, all the markers of oxidative stress are increased, and the neurological symptoms, which could be in the form of dizziness initially, but later on you may have severe coma. This we've already discussed. So the diagnosis, this is something which is very commonly asked in various forums. The diagnosis is basically clinical, and you have to take the history of ingestion or history of exposure. You may or may not get a garlic-like odor from the breath. If the person has ingested a large amount, you may be able to detect this odor from the breath because the phosphine is still coming out. But if it is an inhalational exposure, this is missing. Can you detect phosphine in the breath? Yes. The oldest possible method was silver nitrate breath test. What you do is you make a fresh solution of silver nitrate and you dip a filter paper in it, keep it at the nose of the patient. And if it turns black, then it is, you think that this patient may be having an exposure to phosphine. However, this is a very rough way of detecting. You have detector tubes and you can perform gas chromatography, but this is labor intensive, expensive, may not be available at various centers. If you can establish, you should do this. Management, this is again a question which is being asked, gastric lavage. Well, we all do it, but one thing which I tell my students is the moment you put the tablet in your mouth has saliva and the phosphine starts getting released there, right in your mouth. It goes down the esophagus. It comes in contact with the juices in your esophagus, and then it ends up in your stomach, where it comes in contact with gastric acid. A lot of phosphine is released, and that phosphine either comes out through the breath or it gets absorbed, and it gets rapidly absorbed if it acts on mitochondria very rapidly. So if you are doing a putting in a Rayleigh tube and trying to remove something, all you would remove is aluminum hydroxide. And the point here is, if the patient has come to you late in the course of the illness, there is no way you can remove phosphine from the stomach. A very interesting concept was introduced by a couple of the researchers, that why don't we coat the tablet by giving liquid paraffin or coconut oil? Somebody has ingested that, you give them liquid paraffin or coconut oil. Now the issue here is, as I told you, once you put the tablet in your mouth, it starts releasing phosphine. Once it goes down into your stomach, it has already released large amount of phosphine. Even if you give in an agitated vomiting patient, you want to give them something liquid paraffin which can go into your respiratory tract. And once you force it down their throat, they might vomit it and they might aspirate and have chemical pneumonitis because of that. So I don't think these things should be practiced or should be taught at all, because these are interventions which may cause more harm than good. So, and there is no definitive proof that it would actually prevent release of phosphine. Yes, it sounds reasonable once you've taken the aluminum phosphide tablet with liquid paraffin at the same time. It might still coat the tablet, but if the patient has come late to you in the course of illness, forcing liquid paraffin or coconut oil down his throat is going to land up in major problem. IV magnesium sulfate is a very good membrane stabilizer. It controls arrhythmia. People have used IV amiodarone also, but amiodarone also causes significant hypotension. So that again may contribute to already, in a patient who has significant myocarditis and is having low blood pressure. You give amiodarone to control arrhythmias, it may still lower the blood pressure more. Arrhythmias do improve, but mortality benefit is not there with magnesium sulfate. Steroids have been done in the past. It should not be given at all. Hydration, if the patient is vomiting and you feel that there might be some fluid loss, you may give a small fluid bolus, but overhydrating these patients would lead to a third space loss and would cause more complication. Or oxygen administration, yes, it should be done. Many other therapies have been tried, but there is hardly any benefit. This is a paper which came, a very old paper, again, a case report in 2006, Paul Dargan in England. And you look at the number of interventions, the ones which are highlighted down here is intravenous colloid 1 liter, hydrocortisone, pantoprazole, phenytoin, sodium bicarbonate, N-acetylcysteine, magnesium sulfate, and the patient still died. What about a word about N-acetylcysteine? This is the paper which came way back in 2013. Since we had shown that there is, in our studies, that there is oxidative stress. So the Iranian group thought, can we get rid of this oxidative stress by giving N-acetylcysteine? And in their study, they showed a significant benefit in mortality, may have a therapeutic effect. That's their conclusion. But this is a study which we did at our center, and this was a prospective interventional study. We gave N-acetylcysteine in the dose of 150 milligram per kg IV over 1 hour, and then infusion over 4 hours, continued for next 16 hours in 5% dextrose, and we didn't find any difference in mortality in this study. So I don't know. You want to try it, you can try it, but I don't think there is any significant role of N-acetylcysteine in management of aluminum phosphide poisoning. This is another study which came in later, again from Dr. Hussein's group, and they said that glucose, insulin, potassium infusion in 88 patients of aluminum phosphide probably improves inotropy by altering cell metabolism from fatty acid to carbohydrate and restoring calcium flux, improving the cardiac contractility. They showed a significant improvement in the mortality. We did try to replicate the same study in our population, and we find that, these patients, there was a significant survival benefit, but it happened only in the patients who were mild or moderately poisoned with aluminum phosphide. The ones who had very significant hypotension, which was unresponsive to 3 inotropes, had altered mentation, and had pH which was less than 7 at presentation, they were less likely to improve with this. So you can try glucose, insulin, and potassium infusion. When I looked at what could be the cause of, the difference in survival or effect of GIK infusion, I realized that it could have something to do with the reparative processes of mitochondria. Insulin is a very strong, an agent which kind of upregulates the repair of mitochondria. It does nothing to the final pathway of utilization of either glucose or fatty acid by the myocardial cells. But I think the only effect insulin has is that it enhances the reparative process of mitochondria. What else can be done? There are various things which have been tried. What has stood the test of time is this ECMO. This was a study which was published by my dear friends in a area which is in a town which is less than 100 kilometers from my place. They used ECMO and they found that there is a significant improvement in the mortality if you can initiate ECMO in a severely poisoned patient upfront. There are also case reports of intralipid emulsion, but we haven't found, we conducted a small study, pilot study at our center, and we didn't find any difference of intralipid emulsion in aluminum phosphide poisoning. So what did we do for the patient who came to us? We put in a central line for CVP monitoring, magnesium sulfate for arrhythmias. Since our pH was low, we gave soda bicarb for acidosis. We put the patient on ECMO. Lactate came down in 24 hours. The urine output improved. There was no arrhythmias, and she was weaned off ECMO on day 3, and she was discharged. So this is the algorithm which we now propose. If the patient has come to you and you've clinically assessed, look here, right in the middle. These are the basic investigation you will do, and then clinical and laboratory assessment of organ failure. If there is a circulatory shock, you can give a small bolus to restore IV volume. You can start vasopressor to maintain a MAP of 65 to 70. You can consider GIK infusion upfront if you do not have IABP or ECMO available. But if you have ECMO available, if the patient is on 2 or 3 vasopressors and is non-responsive, you may consider ECMO. But the problem with ECMO is extracorporeal membrane oxygenation, is that it's not widely available. It is labor intensive. It is very expensive. In India, it will cost you 1 day of ECMO therapy would cost you something like 5.5 to 6 lakhs in a government setup. In a private setup, it will be further more. If you look at the second part, if your patient has cardiac arrhythmias, magnesium sulfate will kind of stabilize or improve the arrhythmias. Metabolic acidosis, if the pH is less than 7, you can give soda bicarb, but you have to give it cautiously. Patient is already having a diseased heart. You cannot overload the patient with large volume of IV fluid. So you just bring back the pH to above 7 or up to 7.2, not more than that. You don't want to normalize the pH. Pulmonary edema, you have to oxygenate and ventilate. And if there is a renal failure, you can perform a renal replacement therapy. There has been no proven role of either hemodialysis or hemoperfusion in reversing the pathology here. Can we predict? This is our own prediction model, which is very simple. I think, yeah, this is there is a slide which is missing. This is our own prediction model, which is a pH of less than 7.2, a systolic blood pressure of less than 90, and a Glasgow coma scale of less than 13. If all three are present, that is, the score is 3, 96.4% would die. If all three are absent, that is, score is 0, 100% patients survive. This is with standard of care. This does not include ECMO. So if you have a patient who has all three positive poor prognostic factors, this is the patient upfront may be taken up for ECMO or IABP if the facilities are available. This is something which is very interesting, and you must read this paper if it is possible. This talks about poison-related factors in aluminum phosphide toxicity. If you have added water, alcohol, or juice, and you dissolve the powder, and you have dissolved the tablet in this juice or water or powder, your chances of survival are more. If you have taken it just like that, you put the tablet in your mouth or you put the granules in your mouth directly, then your chances of survival are less. And it also depends on the dose of the poison which you have taken. Does the story end there? No. There is evidence of diffuse capillary leak syndrome, which is causing polyserositis, effusions, ascites, possibly because of endothelial dysfunction. We've published this. A large tablet, when it is ingested, can get stuck in the esophagus. There are very many reports of dysphagia or dinophagia with later on stricture formation. Whenever the aluminum phosphide tablet gets stuck in the esophagus, there is the reaction is exothermic, and it can cause very significant heat release, which will again cause injury to the mucosa and may result in strictures at a later date. We have seen cases of tracheoesophageal fistula forming after the impaction of tablet in the esophagus. So all these complications are there. So what can we do? Stricter controls, increasing awareness, and prompt management, which are the keys factors in managing aluminum phosphide poisoning. So the take-home message from the City Beautiful is that it is a problem which is likely to stay with us, and we need to be aware and we need to be prepared. If you have nothing available with you, no fancy gadgets, you can simply use glucose, insulin, and potassium infusion. And the mortality which we have demonstrated comes down from 60% to 33%. Predicted mortality was around 100% in those patients, not 100%, around 80%, but it came down to around 30%. Whereas if you have ECMO or if you have IABP and dialysis facilities, even the intervention done in a patient where the predicted mortality is 100%, the mortality can be reduced at least by 50% in these patients. The studies on ECMO from Ludhiana, I was just quoting, they have decreased their mortality, predicted mortality from 100% to around 40 to 42% by performing ECMO in these patients. So thank you very much for a patient hearing. If I know there'll be lots of questions, so if you have questions, I'll be more.
I'm sorry.
Thank you, Dr. Bhalla. Wow, that was a fantastic presentation, and really, I mean, I definitely learned a lot, and I think this is such a major challenge for our country, and with our poison center, we've already gotten so many calls on aluminum phosphide, and most of our mortality is around aluminum phosphide so far that we've seen. I really like this GIK. I think that's a very easy option. We have at least something we can start in the especially in like remote settings where we don't have many other fancy things like you mentioned. One question I had around the predictive score that you mentioned. Is there any what if this score is 1 or 2, or is there a mortality kind of a difference with if only one of those is true?
Yes. As I said, I told you there was a slide missing. There was a predictive model which was proposed by Iranian group. It had multiple factors, and when we looked at all these factors, we realized that if we look at pH and a bicarb or a lactate, they basically mean the same thing, right? So we looked at only pH and GCS. GCS is very simple. Anyone can do it clinically. pH is slightly difficult because you need to get an ABG done. So you need to have an arterial blood gas. And the third is a systolic blood pressure, which is less than 90. So if you can get these three, what I was trying to say was, if the score is 0, then the survival is 100%. If the score is 1, the survival is 33%. If the score is 2, the survival is the mortality is 33%. If the score is 2, mortality is 66%. And if the score is 3, mortality is 96.4%. So this is very simple. This is clinical. This can be done at any place. And, you don't need too expensive gadgets there. And if you find that there is a person who has a score of 1 or 2, GIK infusion can easily be instituted. I'm not saying that in the score of 3, you don't give GIK infusion, give it, but it does not affect the mortality as much as it will affect the mortality in score 1 and 2, right? In score 3, the patient is way down the line, and there is very less likely chances of this patient surviving if you do not have ECMO or IABP and dialysis going on. And this patient needs to be in an intensive care, needs a lot of intervention. That's the point which I wanted to say.
Yeah, absolutely. I think, I think for us, like when we are guiding people in really rural settings, we're getting phone calls from. I think this can be helpful, at least in resource allocation and management also, because especially we don't, ECMO is, I think there is, can anyone talk about ECMO in Nepal? Do you know if there is availability? I know some centers do have it, some cardiac centers, but I know it's a very, very rare availability in Nepal. Maybe Dr. Krishna Acharya knows this answer. Or Dr. Rakesh, do you know if ECMO is?
Let me. If you have any facility where there is a CTVS surgery being done or cardiothoracic surgery, they will have the machine, so they can perform ECMO. But For them, the
Yeah.
money making is, cardiothoracic surgery, and they don't want to use the same machine for aluminum phosphide. If you can buy at your poison treatment center an ECMO machine, it's expensive. But if you can buy and you can generate funds, it would be worthwhile.
Yeah. Fantastic. Are there any questions for either Dr. Bhalla or Dr. Krishna Acharya from the audience? You can unmute yourself and ask, or you can type and I can read for you. There was a question about snake antivenoms earlier, I think by Dr. RK. Dr. Krishna Acharya, are you still here? Krishna, Dr. Krishna, तपाईँ हुनुहुन्छ है यहाँ? Okay, maybe he has dropped off. But I think, but the question, yes, go ahead.
May I ask one question, sir? I have written in chat also.
Yes, go ahead.
Yes. As from our first speaker, Dr. KP Acharya, we hear that one child lost his life in Bardia due to the lack of untrained health worker to give anti-snake venom, and two other center are very far to get, one at Surkhet and one at Butwal. So, to overcome all this problem, could we give training to the pharmacist, especially the clinical pharmacist, so that if there is the urgency, if there is the facility center too much far, then they also could give some treatment regarding this?
Do we have Dr. Isa Kharka or Dr. Krishna Acharya who want to take this question?
Additionally, there is a small question in this. In case of
Sorry, Dr. Bikash, you're mute, but I think Dr. Isha is going to answer your first question.
Yes,
I
can.
I'm not a medical doctor, but when we have asked this question in the past, I think there are legal implications to, either intubating or administering, intravenously medicine and so on by someone who's not an MD. I believe that's my understanding of the medical law in Nepal. Maybe the MDs maybe can chime in on this.
Yeah, and Dr. Bikash, I'll say, I think the complication with, I agree that we need to find a way to get treatment available to people, without, because we don't have MDs all over the place, right? Like, so we have snakebite treatment centers in the country that do give, antivenoms in different part of the region. And that's also one of the things that with the poison center, what we try to do is we try to provide guidance to whoever calls, right? Like if a MBBS doctor or a MD doctor does not have experience with it, we have expertise that can help guide when they call. So what we encourage is for anyone that's concerned and that has questions even about treatment or where to send, to call the poison center. I think Dr. Bhalla wanted to add something, and Dr. Sunil Samput also wanted to add something.
I think I would want Dr. Sunil to go first.
Sir, may I add one small question to my previous one?
Give us 1 second. Dr. Sunil is going to say something first.
Sure.
Sorry, Ramu sir, I'm a doctor, doctor. I'm a MSc student, MSc graduate. I'm a snakebite man. I work on snakebite and snake awareness, snake conservation awareness. Basically, I'm a conservationist. I work from, my background is forestry. Having said that, I have a kind of idea by observation that like even paramedics are treating snake bites in Nepal, and they are very, very successful. Like if you take the example of Guru Singhe, which is just in between Rupandi and Kapil Bastu, I assume. There are paramedics posted by trained and posted by Nepal Army, and a person hired by municipality who is treating that one. For that one, government gives approval to treat snake bite in some centers, and they name it as snake bite treatment center. We really do not require doctor as a person to administer anti-snake venom. That's already there in our country, and that had made and improved so many death cases to lives. To be exact, like there are so many cases like that. In Nolpur of Sarlai district, there is a place called Nolpur. There is also same facilities there, and there are so many places in Nepal where these things are being treated by paramedics and those kind of health personnel, and they are a huge resource for us, and thanks to them actually.
Yeah, absolutely. I don't, I don't think this requires MDs or MBBS only. I think there's some training required, but but guidance definitely can be helpful. Dr. Bhalla, do you want to add something to this?
Yeah. Now I wanted to add this. The point which has been raised by Sunil is very valid. Upfront anti-snake venom administration can save lives. But I'll go a step further. Anti-snake venom is not a harmless drug like paracetamol that you give it orally and patients will survive. There is a risk of anaphylaxis, and the risk is real. So if you are saying that you don't need treatment, you don't need training to administer ASV, that's not right. You need training, but you need the right amount of training, how to identify the snake, how to give the anti-snake venom, how to anticipate anaphylaxis, and how to manage anaphylaxis. If you want to learn only this much, fine. To address Vikas's question, I think one of my friends has worked a lot in Nepal. He is from Fresno, and he has worked on the snakebite bike ambulances and things like that. So he's worked here. What I want to tell you is what kills a snakebite patient, which is very important. There are two things which will kill a snakebite patient. If you have a vasculotoxic bite, it is the IV hemolysis and the kidney shutdown which will kill you. You can put in an IV line and start IV fluids. That will take care of a little bit of the problem by keeping the kidneys perfused. Second thing which kills a crate or a cobra bite victim is a respiratory paralysis with a normal lung. So what you need to do is put in a tube, use an ambu. You just don't need oxygen. You just need someone to send the air into your lungs. And if you can maintain it over a transport period to a place where ventilator is available and anti-snake venom is available, you'll save the life. So you need training in two things. One, anti-snake venom administration, recognition of the anaphylaxis and treatment of anaphylaxis. Two, intubation and giving ambu ventilation till the time the patient reaches a place where a ventilator and anti-snake venom is available. That's it. You don't need magic bullets to manage snake bite victims.
Yeah, absolutely. So I think Dr. Rajesh, you had one question. We have only time for one more question, unfortunately. This is a great discussion, but go ahead, Rajesh.
Okay, so what is the management difference between zinc phosphide and aluminum phosphide? So this is my first question. And
no difference. No difference. It is the same.
Is there any question for me?
Sorry, Dr. Krishna. I think Rajesh has a question right
one
now.
One more question. How to give the GIK, like as we discussed about hyperglycemia insulin therapy, GIK therapy. And
Yeah, that I've mentioned my paper. It's available. You just type GIK Ashish Bhalla, you'll get the paper, you'll get the protocol. Just keep it with you and use it.
okay. And one more
Okay.
question. And if we successfully could manage the patient, and what are the follow-up plans? Like you discussed about complication related to the fistulas and strictures. Do you have any follow-up plan
Okay.
regarding the
The
poisoning?
soft pointers towards the esophageal stricture is if the person has hematemesis. When I discussed the case, I said the patient was vomiting, but there was no bleeding. So if there is no bleeding, if it is powder which has been consumed, it will not cause stricture. But if there is slight amount of bleeding, and once the patient has improved and is complaining of difficulty in swallowing, these patients should undergo a upper GI endoscopy upfront. So you can detect whether there is any injury to the esophagus, and then you can keep them on follow-up. If they develop symptoms of, or they have progressive increase in symptoms of dysphagia, then they can come and then you can do a dilatation, or very rarely you would require a surgery.
Thank you. That's all.
Okay, thank you. Thank you, everyone. I think that's all the time we have for today. And at the end, I would like to invite our beloved professor from TUTH, Dr. Sangaratna Bajracharya. He is also in the Medical Education Commission in Nepal, and he's part of the Clinical Pharmacology Department, to give a few words of thanks to our speakers today and our participant. Please, Dr. Sangaratna.
Okay, thank you. Thank you, Dr. Ramu. So I'm very happy to express my thanks. Actually, I'm very thankful, and it has been very much learning experience for all of us. So our learned speakers, Professor Ashish Bhalla, he had enlightened us with various aspects of aluminum phosphide poisoning, highlighting the common algorithm along with various resources, and a discussion on important aspects. And also, like, it was so nice to hear that, like, he has presented his views and experiences out of treating so many cases during his practice. We should be cautious about secondary infection, but like we should not be so much panic about it. Once we know, like, somebody who are very experienced, has some experience, I mean, they have got some exposure where, like, we might be bit reluctant what to do. So I like sharing of ideas from those expert people would help us go further, like go smoothly with the treatment. Thank you, sir. Thank you, Ashish Bhalla, sir, for your very nice presentation. So we'd like to hear from you again and again in this forum. And I would also like to thank
much. And
Dr. Thank you, sir. Thank you, sir. I would also like to thank Dr. KP Krishna Prasad Acharya, sir, so who had contributed a lot in poison management in Nepal, and he has shared so many of his experiences and cases where, you know, he had found typical incidences and also the problems associated with treatment during treatment of poisoning. And I was also happy to know that, like, this snake bite, although it is dead, it has already been registered as neglected tropical disease. It has got some of the importance as one of the tropical disease in our setup. Also happy to see various data, and happy to know that out of the poisoning that we have, only 10 to 15% are venomous. So I would not like to spend a lot of time since it's already late, and I would like to thank especially the coordinator for this for conducting this program. I would like to thank Dr. Ramu and also other participants from Brown Universities and Ask Foundation. Similarly, like I would like to thank the members of PIC Nepal and also my department family members, along with all the participants. We had around 80 participants, although we have now 60 participants, all the talks and like our enthusiasm maintained during the session. So I thank you all, and I expect all of you plus your colleagues and others academic activities that will help for poison with this. I would like to thank you all once again. Thank you.
Thank you, Acharya sir, and yeah, thank you everyone. Before you go, एउटा चाहिँ please एउटा feedback form छ है हाम्रो यो आजको कार्यक्रमको, so that हामीले पछिको कार्यक्रम कसरी बेटर गराउने त्यसको लागि it will be really helpful. यो मैले लिंक राखेको छु यो on the chat, so please go ahead and fill that out. And then again, to remind yourself, हाम्रो poison center को phone number is 450-2011. So कुनै पनि question, aluminum phosphide host, zinc phosphide, snakebite, you can call and find out the information. जस्तै कहाँ पठाउने, कहाँ नजिकै छ, या what's the next step. And we have experts like Dr. Ashish Bhalla, Dr. Krishna,